Good afternoon, everyone. Well, I would like to start thanking everyone for joining us this afternoon. I would like to thank our speakers. We have a very rich pool of speakers today that will be introduced in a few minutes. My name is Mohammed Zatar, and I'm the sales manager for BVI in the Middle East and North Africa. And I could tell you that this is going to be a very interesting webinar with physio experts who will enrich us with a lot of solid information about their experience with the premium IOLs. Well, normally there has been many talks about premium IOLs done so far, even by physio. But still we face sometimes important feedbacks about a patient that is not happy, or to which IOL should we fit him, and that's why we decided to conduct this webinar. Of course, if you are a surgeon who chooses to offer presbyopic correcting intraocular lens to your patient, in addition to the limitations that premium IOLs offer, you are always quickly faced with the problem of matching the IOL to each patient's lifestyle, which isn't always easy. So in this webinar, we'll take a look at the trifocal experience from Physiol's fine vision experts, and we as well as the Isopure extended depth of vision clinical outcomes. And we will see who isn't a suitable candidate for premium IOLs and how to successfully avoid creating unhappy patients post-op. So allow me to introduce our moderator, Professor Ahmed Assaf, who is very well known, but briefly let me say that he is a professor of ophthalmology in the Faculty of Medicine at Ain Shams University in Egypt, and he's a fellow of the Royal College of Surgeons in Edinburgh and consultant, phaco-refractive surgery, and shareholder in Al Watani Eye Hospital in Cairo. Of course, Dr. Assaf, he has done so many premium cataract surgeons using premium IOLs since many years, and he has many international peer-reviewed articles and presented a lot of presentations in international meetings. So thank you, Professor Assaf, for being with us and for moderating this session. I remember you told me once that in an ideal world, if the surgeon and his team take the time to discuss realistic expectations for presbyopic correcting lens, then most patients are happy regardless of their personality. I remember this statement very well, so I give you now the lead to moderate this session.
Thank you very much, Dr. Zatar, for this introduction. Thank you, BVI and Physio, for hosting this event about the expert talk about the premium IOLs. We have an expert in premium IOLs, Dr. Ala Danasori, Dr. Rafael Balbao, and Dr. Arif Adinwala. Let me start by introducing Dr. Ala Danasori. He's a Chief Medical Officer and Director of Corian Refractive Surgery Unit in Maghrabi Hospital Centers, and board member of many international societies like the ICO, II International Intraocular Club, and the American European Congress, and many others. He's a former president of ISRS, and he has a vast experience in refractive and corneal surgery. His CV will take about more than 30 minutes to finish his CV. So he has got many international awards, and we shall stop like this. Please, Dr. Ala Danasori, you can introduce, you can start your presentation, then we'll shift to other speakers. I think you are muting.
Okay, thank you, Ahmed, and thank you, Mohammed, for the kind introduction. And welcome all attendees, and Ramadan Kareem for everyone who is celebrating Ramadan. In this talk, I'm going to share with you my experience with the trifocal lenses, which started some 5 or 6 years ago when I was introduced to the trifocal lenses. Mohammed, can the attendees post questions on the Q&A or chat?
Yes, we can take after each presentation 2 or 3 questions, and at the end, if there are
can I type questions?
Yes, of course. Yes, okay. Yes, they can.
Okay, so you can type your questions on the box in the chatting box, which will be answered during the presentation. Now, these are my financial disclosures. I'm consulting to Physiol, who is manufacturing the very first trifocal IOL. Now, to get started, let's agree that when we talk about multifocality, we're talking about an optical compromise. Whatever we do, wherever we go, multifocality is always an optical compromise. This needs to be in our background when we talk about any multifocal IOL. And compromise means that you're giving something to take another thing that you need. So how much compromise we are doing, how much giving we are giving in order to take, this is a big question. And that's why 20 years ago, when the bifocal lenses that were called multifocal at that time was introduced, it did not make it to the mainstream in ophthalmology practice. At least in my practice, I used some of this and then I immediately stopped because the compromise here is not in the advantage of the patient. The patient didn't like this compromise, mainly because bifocal lenses give a poor intermediate vision. That's the big thing. Bifocal lenses has photic phenomena that patients are suffering from. It's true that they give good far and good near vision, but that's all. And this led to a very long chair time, a relatively high rate of patients who are unsatisfied, exchange of the multifocal. That's why the bifocal never made it in the mainstream. And these days, more than ever, intermediate vision is very important. What we are doing now in this webinar is intermediate vision. Most of our activities involve some kind of intermediate vision with the screen time that is increasing dramatically this year. So intermediate vision is not less important than near vision for our patients. Now, when the Physiol introduced the fine vision due to the brilliant, simple, and by the way, most of the brilliant ideas are simple. The simple but brilliant idea of our friend Damien Gatinel with Mr. Parnouille from Physiol, and they decided that it would be a good idea to combine two diffractive lenses. Very simple idea, but it was brilliant. So to give the patient what they need, far, intermediate, and near. And then they worked on the quality of vision by different manufacturing maneuvers like apodization, which gives more light energy when the pupil is small when you're reading to the near vision, and more energy to the far vision when the pupil is large. Convolution or smoothing, this improved a lot of the quality of vision that was not the case with the bifocal lenses. Toricity today is very important. More than 50% of our patients need toric lenses, and asphericity to compensate for some of the positive spherical aberrations of the cornea. When it was introduced, hydrophilic lenses were only available. I used this and I'm still using this. I'm very happy with the hydrophilic. I have nothing against hydrophilic lenses. Actually, I like it because of the excellent quality of vision. But we know that this is a big debate, and many surgeons, many excellent surgeons that I know would not use hydrophilic. They was only hydrophobic, and they are waiting for the hydrophobic Pod F and Pod FT, which is already available in Europe, and I knew that it will be launched in Saudi in the next few weeks. So that would be a good for those who like the hydrophobic lenses. When we talk theoretically on the bench, on an optical bench, Damien and his team proved that trifocal lens with the Pod and Pod FT is truly trifocal, and they compared it to the previous bifocal lenses and the EDOF lenses, and they showed the superiority of this lens. But at the end of the day, this is lab work. This is an optical bench. What is important for us is how these lenses perform in the patient's eye. So when I started using the trifocal lenses, I was a bit skeptical because I came from a bad experience with the bifocal lenses. I was not very excited to restart my multifocal experience. And then soon I realized that trifocal experience is totally different than the bifocal experience. So at the beginning, the first study we did on this lens was a prospective consecutive study on 36 patients, bilateral. All these patients had either cataract or refractive lens exchange. And we excluded patients who might have any reason for a poor quality of vision after surgery. So we, for example, patients with Fuchs dystrophy were excluded because this will not be excluded in my everyday practice, but in this study, we excluded any case that can induce poor quality of vision after surgery with the trifocal lenses. We excluded, of course, patients with early keratoconus, patients with corneal scar that induce high corneal aberration, like in this case. Post-refractive surgeries were excluded because they have a high corneal aberrations. But having said that, many of the patients who had decent corneal surgery, like in this case, should not be excluded from trifocal lenses, like in this case, who had a hyperopic aberration, but his corneal high-order aberration is still within normal range. So this patient can have a trifocal lens. But for the sake of our study, we excluded any patients with previous ocular refractive, corneal refractive surgery. We included patients with angle alpha and angle kappa less than 0.6 millimeters. So we excluded anyone who has a high angle kappa. We also did a tear film analysis for every patient, and we included only patients with stable and good tear film. Patients like this one on your right hand side was excluded because this will compromise the quality of vision after surgery. More than half of our patients had toric trifocal, because as you know, the corneal astigmatism is not uncommon. And we use toric lenses for anyone who has 1 diopter or more of corneal astigmatism. We actually go down to 0.75 if the astigmatism is against the rule. An important tip here for the especially for the toric lenses, that we have to use a decent alignment system. We are using here the Callisto system from Zeiss. I have no financial interest, but I found that this improved a lot our alignment with the toric lenses. But another important tip is to remove the viscoelastic behind the lens. I'm doing this on every patient, every time, 100% of the time, because this will allow the lens to become adherent to the posterior capsule fast, and it will not rotate in the early post-operative period. So now we have 36 patients, 72 eyes. We examined every possible parameter that can be lead to improving our knowledge about these lenses. Looked at the far, intermediate, and near vision, uncorrected and corrected. We looked at the range of pseudo accommodation with the defocus curve. We measure the quality of vision. We measure the scatter, the objective scatter index with the Hdi Analyzer. We measure the entire eye high order aberrations with the OPD scan 3. We measure the corneal high order aberrations. We looked at the modulation transfer function and the contrast sensitivity test using the Hdi automated contrast sensitivity system. And we had a patient questionnaire, a subjective questionnaire at the end of the 6 months. And this study is already in press. It should appear in the Journal of Refractive Surgery maybe in a few months. And you will find all the details in this paper. I would claim that this is a class A paper that took a lot of time and a lot of effort in putting all this information together. So at 6 months, we had 89% of our patients were between plus and minus half. We used the Barrett formula for the calculation, the Barrett for spheric, and also the Barrett toric calculator for the toric lenses. We found it in our hands, giving very accurate results. When we looked at the uncorrected visual acuity at 6 months, that's monoocular, 100% of our patients could see 30 or better, and 90% could see 25 or better with monoocularly. Binocularly, 94% could see 25 or better, which is excellent vision for this age group. When we come to the near vision, and here I'd like to go slowly for a few minutes, because it's very important to know how to measure the near vision. The majority of the studies, even published in peer-reviewed studies, are using near vision charts that are not accurate, that are not approved, especially the Rosenbaum card, which is very commonly used. What we used in our study was the Sloan chart on the clinical trial suite. And this is an automated system that is software-based, and it eliminates the technician bias. It generates automated defocus curve. It's randomized, so the patient cannot rely on any memory. It, of course, is using the Sloan chart, not the E letters. And it can measure the far, intermediate, and near vision. So this is what we use. Of course, we cannot do this for every regular patient because it takes a good 10 minutes per patient. But we've done this on all our patients that are included in this study. So at 1 month, 86 of our patients had a 20/30 or better distant corrected near visual acuity. And again, when you need to measure the near vision, when you want to measure the performance of the lens at near, you have to use the distant corrected near visual acuity. Because simply if you use the uncorrected vision, if the patient has a -1, he will have an excellent near vision. This doesn't mean that the lens is good for the near vision. So we use the distant corrected near visual acuity, and 86% of our patients could see 20/30 or better. At 6 months, 94% of the patients could see 20/30 or better, which was excellent outcome for this type of lens. The intermediate vision at 80 centimeters, we still use the clinical trial suite. At 1 month, 86% could see 20/30 or better. At 6 months, more than 90% were seeing 20/30 or better at 80 centimeters with their distant corrections. We looked at the defocus curve, and just to give you a brief idea on what is the defocus curve for those who are not aware of this, the defocus curve measures the ability of pseudo accommodation at different distances. So you put the distant corrected vision of the patient in front of the trial frame or phoropter, and then you start to add lenses between +2 and -5 lenses at random, and you measure the vision with these lenses. This measures the pseudo accommodation ability of this eye. So this is how a defocus curve of a young non-presbyopic patient with clear lens would look like. Excellent vision for distant, intermediate, and near vision. Now, for a monofocal lens, this is how it will look. Excellent vision for far vision, and then it drops down quickly for the intermediate, and he has a very poor near vision. This is a bifocal lens, restore or resume lenses, a good distant vision, good near vision, but in between there is a trough here, and that's what made the patient very unhappy with this kind of lenses. Shown in red is the trifocal, the defocus curve of the trifocal lens. You can see excellent far vision, excellent near vision, and the intermediate vision is still excellent. It's more than 0.1 in logMAR. So this patient actually can see better than 20/30 in all distances. And this is the big thing about this lens. Now we know, and we said at the beginning, that multifocality is an optical compromise. So we had to measure the contrast sensitivity, and here we used the HAC system, which is part of the clinical trial suite, also with glare and without glare at mesopic condition. And we found that the trifocal lenses decrease the contrast sensitivity, and hence there is some effect on the quality of vision, but a small effect, like you can see here. The dashed line is the normal population, and the red light is the trifocal lenses contrast sensitivity without glare, and the gray curve shows the contrast sensitivity with glare at mesopic condition. So there is a little bit, and this is what the patient is paying in order to have an excellent intermediate and near vision. So why these lenses induce some visual issues? Mainly because of the scatter. And the only device that I know that is measuring the scatter objectively now in clinical setup is the Hdi Analyzer. And you can see here a patient on the left-hand side is the preoperative Hdi Analyzer. You see an objective scatter index of 6.6 down here. After surgery, this went to 1.2. The lower the number, the better the quality of vision. So this patient benefited a lot after the surgery. His potential visual acuity before surgery was 0.3. In decimal, after the surgery is 1.3. So he had an excellent visual acuity. And the patient also got rid of his glasses because he had around +2 hypermetropia before surgery. After the surgery, he went in emmetropic. So this patient had gain in all aspects. Better quality of vision. He got rid of his glasses, better near vision, better intermediate vision, and a better quality of vision. So this is an example of an excellent, extremely satisfied patient. But keep in mind here that when we're looking about cataract patients, is different than clear lens extraction patient, refractive lens exchange, because this patient starts from different background. The cataract patient starts from a poor quality of vision, but the refractive lens exchange starts from an excellent quality of vision. So keep in mind that multifocal lenses, trifocal lenses is going to improve the OSI for the patient with cataract, but it's going to decrease the OSI, to increase the scatter for those patients with a clear lens. So keep this in mind during your patient counseling. An example of some of our patients in this study, preoperatively, he had some cataract, he has hyperope, he is presbyope. So after the surgery, he definitely improved dramatically, and the patient is extremely happy. He gained everything, and he didn't lose anything. So this patient is extremely happy. Now, another patient had a clear lens, but he's presbyope. He's 50 years old and hyperope. So this patient, after the surgery, got rid of his 3 diopters of hyperopia. So he's happy. Better near vision. He restored his near vision, so he's happy. He's very good intermediate vision, and he maintained the quality of vision. He had a good quality of vision before the surgery, and after surgery, he still has a good quality of vision, as shown with the OSI, preoperatively 1.2, post-operatively the same number. So this patient is also very happy. Now, this patient is, I want to draw your attention to, this is a critical patient, a young patient, 25 years old or 35 years old, with excellent optics, excellent quality of vision. The OSI is 0.6, perfect optics, but the patient is hypermetrope and he has a high hyperopia. So this is the patient that you need to counsel properly, because you have to test the motivation of this patient. If this patient is highly motivated to get rid of his spectacles or contact lenses, then this patient will be happy, because he is maintaining the near vision, he's maintaining the intermediate vision, he's getting rid of his spectacles, but he's losing some quality of vision because of the trifocality. So these are the patients that really need to be properly informed. And I have so many extremely young patients, hyperopes, who had the trifocal lenses and are extremely happy. At 6 months, we gave the patient a subjective questionnaire. All of them were happy. All of them would have the surgery again. None of them was dissatisfied with at any distance. Only 12% spontaneously reported halos at night. But when you ask them, the majority of the patient will have some photic phenomena, but the typical answer would be yes, we see some glare around light, especially when we are driving at night. But this is not bothering us. This is a very little price to pay if we're going to in order to be able to see intermediate and near vision. So this is really a thing that I love to hear from my patients. So in conclusion, trifocal lenses, the POD and POD-FT, gave a satisfactory far, intermediate, and near vision. Toric trifocal are essential and effective and important for compensating astigmatism. The impact of visual on the quality of vision, although it is there, but it's very little, it's very acceptable, but you need to know how much compromise this patient should be able to give in order to be happy and satisfied after the surgery. At the end of the day, does not restore the accommodation, but actually it provides an efficient compensation for the loss of accommodations. I always recommend to measure the quality of vision before the surgery, whether with the scatter or with the high order aberrations, whatever machine you have, the entire eye quality of vision. You need to know how good this patient is seeing, and then you can anticipate the level of satisfaction. Always target emmetropia with trifocal lenses. Axis alignment is extremely important. Exclude patients with preoperative high order aberrations and large angle kappa, angle alpha, and so on. Be careful for your patients with refractive lens exchange, and never ever overpromise. And finally, I'd like to acknowledge my team that worked together on this study for a few years. All of them did a great job, and I'll be happy to see the paper published in the next maybe month or 2 months in the JRS. And I thank you for your kind attention.
Thank you very much, Dr. Ala, for this great presentation. We have a couple of questions from the audience. While you stop sharing your screen, I will present the questions for you. First question is this: the trifocal lens is a pupil-dependent lens, and what is the near vision distance for this trifocal lens?
We measure the near vision at 40 centimeters and the intermediate vision at 80 centimeters. That's what the lens is made for. The lens is pupil dependent. It's not pupil dependent, but the pupil affects the performance of lens because of the apodization. So you have the height of the steps decrease at the periphery. So if the pupil goes larger, then more energy goes to the far vision. If the pupil goes smaller, and that's what happens usually when we read with the near reflex, then more energy goes to the reading. So that's the apodization, and that's helpful with these lenses.
Would you use the CTR to add the stability of the lens or effective lens position in such premium lenses?
Yeah, I like the question. I was using CTR for my bifocal lenses before because of the higher rate of exchange. But with the trifocal lenses, when I started, I had the same practice at the beginning, and then now, no, I do not use TCR as a routine for my trifocal lenses. And here I encourage everyone not to use the term multifocal, because multifocal is very confusing. It's either bifocal, which is part of history now, or trifocal, which is totally different.
What is the lowest amount of corneal astigmatism would you go with the premium lens?
Well, with the toric lens, you can correct up to 6 diopters of astigmatism. So there is no minimum astigmatism, but maybe he means with the spherical lenses.
Yes.
Yeah. So with the spherical, anyone who has a corneal astigmatism of 1 diopter or more receives a toric lens. If the astigmatism is against the rule, I'm more conservative. I'll go with the trifocal lenses for even 0.75 against the rule. If the astigmatism is with the rule, then you can go from 1 or 1.25. So one is the magic number. Anything above 1 should have toric lenses.
Okay, thank you very much. Now we'll shift to the next speaker, Dr. Rafael Balbao from Spain. He is a consultant ophthalmologist in Clinica Baviera in Spain and United Kingdom. He has many international publications and chapter author of many books. He has special interest in premium IOLs and expert in trifocal and EDOF lenses. He is invited speaker in many international congress and director of 5 national teaching courses. Please, Dr. Rafael Balbao, he will talk about his clinical and personal outcomes with Isopure lens over the last 18 months. Please, Dr. Rafael Balbao, it's all yours.
Thank you very much, Dr. Ahmed, for your very kind presentation. I would like also to thank Mohammed and Physiol for the invitation to participate in this great meeting on premium IOLs. And I would like to really wish all my colleagues and to all the attendants a very happy Ramadan time here from Madrid in Spain. I would like to present you my experience during the last 18 months with the Isopure lens. These are my financial disclosure. I would like to stress that I have no financial interest in any of the products mentioned in this talk. And I would like to acknowledge my optometrist colleagues teams, Alba Fernandez, Gloria Bosque, and very especially Victor Tejerina, who helped me very much in this study I'm going to present to you. In 2021, nowadays, trifocal diffractive lenses, as Ala mentioned in his presentation, are considered the lenses gold standard for the correction of presbyopia. However, as you all know, these trifocal lenses present some limitations, such as anatomic contraindication for some patients, some undesirable visual effects that are sometimes unacceptable and other times not recommended for some certain activities of our patients. And sometimes also they may present an economic limitation for its implementation in all the patients. And this is why around 6 or 7 years ago, EDOF lenses were launched into the European market. As you all know, EDOF, the term EDOF, extended depth of focus, referred to the lenses, is a term that is often confusing and controversial. In fact, the first called EDOF lens is a low addition bifocal diffractive lens. And as you also know, diffractive and refractive optics generate more than one single focus. In 2014, initially the FDA and later the American Academy of Ophthalmology and ANSI defined EDOF lenses, but only did it by functional outcomes criteria. And all these three organizations lacked to consider the mechanism of action of these lenses and thereby their visual secondary effect these lenses were having on the patients that were receiving these lenses. As you all know, EDOF lenses work with different mechanisms, and they have different, completely different optical strategies, and thereafter they show different performances. As a summary, in my opinion, EDOF lenses could be divided into hybrid multifocal EDOF lenses, where these lenses share part of their optic qualities as a diffractive optic or refractive zonal optic, and what we should really call true EDOF lenses can be divided in three different mechanisms of action: small aperture lenses, inlaid optical devices such as Axicon, inserted lenses in the optic, and lenses, monofocal lenses with modification in the spherical aberration, what we should maybe call monofocal plus lenses. Today, we are going to speak about the Isopure lens, which is a lens, a monofocal lens with a modification in the spherical aberration. The Isopure is a preloaded hydrophobic glistening-free lens with no diffractive or zonal refractive profile, with thereby no loss of energy, and as easy to handle as a monofocal lens. The lens platform is based on the MicroPure platform, which is a hydrophobic glistening-free preloaded lens with which we have an extensive experience in Clínica Baviera with over 7,000 implants in Spain, with excellent results in vision, refractive outcomes, anatomic, and PCO rates. The Isopure works thanks to the polynomial complex surface design that increases negative spherical aberration of the lens. It displays a centripetal progressively increasing dioptric power map that extends the depth of focus in comparison to the monofocal predecessor up to 48%. Besides, Isopure was customized to provide a more negative spherical aberration in higher power lenses, usually used in hyperopic patients which have a more positive corneal spherical aberration on average. And besides that, these lenses in the optical bench studies has shown an EDOF gain that is almost pupil independent. It persists even with larger pupils compared to other similar EDOF lenses. We decided in the summer of 2019 to perform prospective clinical pilot studies in which we perform cataract surgeries, not clear lens refractive exchange, in patients that were otherwise healthy with less than 1.5 diopters of corneal astigmatism. And we aim as a target emetropia, and when the lenses were implanted bilaterally in one of the eyes, we aim a small negative defect. This is a very short video clip with the first implant we performed worldwide in Madrid. We were lucky to do it in July 2019. As you may know, the implantation of the lens that is preloaded in the 123 cartridge, it's very easy. It's a very friendly lens to be implanted. And although you have to follow carefully the instructions provided by the manufacturer, it's very friendly, and as you can see in the video, very easy to manipulate and to implant in the bag. I really love very much the Micro F platform, and with this hydrophobic lens, it works very well and very easy. They're very easy to manipulate inside the eye. I perform in many cases hydroimplantation to avoid the cleaning of the viscoelastic behind the lens. This is a picture of this first patient 1 month postoperatively. These are the results we obtained in this pilot study. We followed 37 eyes from 22 patients for more than 6 months, and we observe a cylinder reduction compared to the preoperative values. This is a summary of the vision we obtain with the patients in all the distances. If we disclose it by distance uncorrected vision was around 0.84. You have to consider that some of these eyes were target for small myopia. When corrected, they were around 20/20 visual acuity. Consider intermediate visual acuity at 80 centimeters. This is what we used for the computer. Uncorrected, it was around 0.6, corrected around 0.65. And at 66 centimeters, which is a distance we use normally with our tablets, uncorrected 0.55, corrected around 0.6. Considering binocular visual acuity, these are the most important results. In the distance, patients could see practically like a monofocal lens, around 20/20 vision. In 80 centimeters, around 0.8, and 66 centimeters, around 0.75. In summary, the patients obtain a very good outcomes of vision, a visual acuity for the distance, a very good intermediate monocular and binocular visual acuity. And what it was also very good news for us is that many patients could get over 20/40 vision at 40 centimeters. And this would allow patients to do many things in the near distance without the need of reading glasses. Considering the defocus curve we obtained, both monocular and binocular showed an extension in the defocus curve compared to a monofocal lens, and patients obtain, when implanted monocularly, a vision over 0.2 logmar from the distance to 77 centimeters when implanted monocularly or when considered monocularly, and from distance to 62 centimeters when we considered binocular implantation. And regarding contrast sensitivity, we obtain normal values in monocular, binocular, photopic, and scotopic values that are comparable to this age group. You must remember that these patients were cataract patients and the mean age was around 70 years of age. We also performed for patients that were implanted binocularly a check of the visual quality and the quality of life with two validated questionnaires. We use this questionnaire to evaluate the quality of the vision with these two questions, and 90% of the patients show or refer no starbursts or halos, and if so, it was only minimal and not all the time. And the same thing for the glare. 90% of patients implanted bilaterally didn't refer any glare, and if so, it was not bothersome. Considering the independence of glasses, we performed this PRISC questionnaire, and 90% of patients do not need glasses when implanted binocularly for the distance or the intermediate vision, and half of them were able to function comfortably without glasses at near vision, very often, not for very demanding or long time activities, but for certain activities they could do it with good illumination without the need of near glasses. What does this Isopure lens provide us for our patients against the classic aspheric monofocal lens? This lens provides an extension of a single focal point from the distance to the intermediate vision. And we think this can be enhanced with this when this lens is implanted binocularly with a certain mini or micro monovision strategy, without the negative effects and contraindications that we all know monovision has when we perform it with more classic monofocal lenses. We get to extend the focus around 1.5 diopters, widening the defocus curves and showing a better tolerance to residual anisometropia. And this gets our patient to get a greater spectacle independence that is virtually unnecessary for intermediate vision. And although patients need glasses for the reading, usually they're lower edition and less needed for these near activities. What does it bring compared to the monofocal lenses? A similar distance vision. Patient will be able to drive without the starbursts or halos that are often a problem with diffractive lenses. They'll be able to see the TV subtitles. This lens will offer to our patient a better and useful uncorrected intermediate vision that the patient will be able to walk with better safety profile over uneven surfaces. The patient will be able to see the car dashboard, the computer, the tablet, will be able to play cards, cook and eat, and see a ticket price or browse the newspaper without the need of glasses, and also provides a somehow better near vision. Compared to the diffractive and refractive zonal multifocal or EDOF lenses, this Isopure lens, we think it improves the quality of vision, as there is no division of light and there is no loss of light. There is no significant reduction in contrast sensitivity. There are no dysphotopic phenomena added, such as halos or glare or starburst, and this lens is less influenced by ocular comorbidities of the patient, such as a worse ocular surface quality, less corneal irregularities, or if the lens is not as well centered as it should be with a multifocal lens. And also this lens provides a relatively good vision compared to a multifocal lens if the patient is suffering of a minimal or of a minor macular or optic nerve problem. It provides simplicity in the patient's management compared to the multifocal lenses. There are fewer medical contraindications, fewer professional contraindications, fewer psychological contraindications from the patient, and it's less demanding on any need of preoperative technology. This is something very important. And for us as a clinician, that we have to spend a lot of time explaining to the patient, these type of lenses help us to save some time in the explanation. But we always must remember that this lens provides also less spectacle independence compared to the gold standard, which are the trifocal lenses. The ideal profile candidate for this lens is an active profile in all lighting conditions, not willing to accept the visual disturbances associated with multifocality, the patient shouldn't mind to wear reading glasses occasionally, and we must use these lenses in patients with a minor possibility to get an ametropia postoperatively. We think honestly that these lenses are suitable for routine cataract surgery. How do we manage these patients? We aim to target one eye for metropia, the second eye for a minimal myopia, around 0.5 myopia. There are some corneal contraindications. We shouldn't use these lenses in patients with high astigmatism, and this is something we would like to stress to physio. If they were able to launch a toric lens, we would be extremely happy. And we shouldn't use these lenses in patients with a high preoperative negative corneal spherical aberration, patients with keratoconic corneas or previously treated with Presby Lasik or hyperopic PRK or Lasik with a high initial negative spherical aberration are not the best candidates. Other exclusion could be patients with severe maculopathies or severe optic neuropathies or corneal disease that wouldn't get too much gain compared to a classic monofocal aspheric lens. In conclusion, the new Isopure lens seems to provide a very good distance vision quality combined with a visual improvement in intermediate vision by accentuating the EDOF effect without inducing photic effects. And compared to its monofocal predecessor, this is what was more interesting for us, it provides a similar distance vision, similar photopic and mesopic contrast sensitivity curves, a clear improvement in the defocus curve, and a better tolerance to residual ametropia. A mini monovision strategies improves the binocular intermediate vision without modifying significantly binocular distance and near vision. And we obtain a very high level of patient satisfaction with a very reasonable spectacle independence obtained when this was adequately explained to the patients preoperatively. We need further studies to confirm these initial results and to directly compare these outcomes with the monofocal predecessor and to investigate how really this lens works in relation to some optical conditions such as the physiological changes in the pupil size with the changes in the pupil centration with different dioptic powers and in scotopic conditions. But in conclusion, we could summarize that this lens could be possibly used in some ocular conditions, consider contraindication for multifocal lens implantations. This lens, we think, could be better addressed as a monofocal plus lens with an extended depth of focus, as it extends the uncorrected depth of focus and improves spectacle independence. Thank you very much to all the audience.
Thank you very much, Dr. Rafael. A very nice presentation, and you highlighted the values and the merits of the new extended depth of focus, the refractive one, not the diffractive one. So I have a question for you. Would you compare, how could you compare this lens to the Eyhance lens, the other competitor?
We, in Clinica Baviera, we are testing different lenses that are globalized in the EDOF term of lenses, and one of them is the Eyhance, which is a lens that works optically in a very similar way, but our results show a larger widening of the defocus curve. I think basically compared to the Eyhance, under mesopic and scotopic conditions, the extension of the focus, I think, is better. There was a very interesting published study evaluating the EDOF effect with the Eyhance, and the Eyhance lens works well, but only if the pupil is below 3 millimeters of size. Whereas with the Isopure, we have found the result in the extension of the focus are maintained even with larger pupils. But the glasses independence, I think it's similar to the lens, but the extension of the focus is probably slightly higher with the Isopure, yes.
Yes, I think you are right. Johnson & Johnson market the Eyhance lens as a monofocal lens plus. It's not an EDOF lens. So let's make things clear. So most probably the Isopure has a more depth of focus compared to the other lenses. And that's why, as you confirm this with your studies, that the focus curve is more broad with the Isopure lens compared to the Eyhance lens. So would you recommend the Isopure lens in patients with post-myopic Lasik?
I have used it in few patients post-myopic Lasik, and this is a difficult question because difficult to explain, but because normally in a patient that has been previously treated for myopia, you have a positive spherical aberration. What you're adding with an Isopure is a negative spherical aberration. I don't know why, but in these patients, the results are especially good. I don't know if it's the combination of a highly positive spherical aberration optic in the cornea, and behind that, a high negative spherical aberration, but these patients get even broader spectacle independence, or even broader defocus curve, and the results, especially when they have small pupils, is excellent, magnificent. So I think it's an excellent option for patients treated previously with myopic laser. I haven't tried it in post-hyperopic, as I mentioned before, and I would not recommend it in prolate, hyperprolate corneas previously treated for presby Lasik or for hyperopic Lasik.
Yes, I agree with you that post-myopic LASIK, I think the patient will enjoy excellent quality of vision because the high negative spherical aberration on the surface of the lens will compensate for the induced positive spherical aberration after laser vision correction in post-myopic LASIK. And as you mentioned, we have to stress to the audience that it's not recommended, even by the company, that to be used with post-hyperopic LASIK, because you will add more and more negative spherical aberration, and this may jeopardize the quality of vision at distance. So maybe it's not recommended for the post-hyperopic LASIK, but I think it's recommended or highly recommended in patients with post-myopic LASIK. Final question before we move to the next speaker. Would you try to mix and match the EDOF lens and trifocal lens?
To be honest with you, I have a very large experience with multifocal lenses, different types, and I don't like mix and matching different optical strategies. I think every, especially diffractive and refractive, zonal refractive lenses have, as Ala mentioned previously in his presentation, very good points regarding glasses independence, but the neuroadaptation is not very easy sometimes. I think all these lenses work much, much better when they're binocularly implanted. So I'm not very keen on using multifocal and monofocal lenses in the other eye. What I don't think is a problem, and I have used it in some of my patients, is a classic aspheric monofocal lens and a monofocal plus lens such as Isopure in the other eye, because basically the optical mechanism is the same. It's a monofocal lens, and what provides the Isopure is a better intermediate vision, but the neuroadaptation would be the same. But diffractive trifocal or bifocal in one eye and an Isopure in the other eye, I maybe could work, but I don't see it. I wouldn't recommend it as my initial choice.
Okay, I think let me stress that because we did a lot of mix and match. I did it myself. I did it on my mom, by the way. I'm planning to have mix and match from other companies. I think we had to do this to overcome some of the defects of the bifocal lenses in the past, in the last decade. But because of the improved technology with the trifocal lenses and now the new EDOF lenses, whether the diffractive based or the refractive ones, I think mix and match is not a good idea. I think we can implant the same lens on either eye and we will get an excellent results. I think because of the technology has been improved, mix and match is not the idea for at least for the meantime.
Yes, I used to do mix and match with bifocal diffractive lenses with different additions. This wasn't a strategy, but it was the same optical strategy for both eyes, diffractive, bifocal. But since the beginning of trifocal lenses, as a multifocal lens for patients, to offer patients to get rid of the glasses, I honestly think trifocal lenses are the gold standard. And yes, I don't like to mix different optical strategies, as I mentioned before. Yes, thank you.
Thank you very much. Now we'll shift the gear to Dr. Arif Adwenala. He's a cataract and refractive surgeon working at NMSC Royal Hospital in Sharjah and Dubai. He has more than 20 experience in ophthalmology and refractive surgery. He is a member of the international ophthalmic societies, an active and regular participant in many international congresses, and received the educational award from the American Academy of Ophthalmology. Dr. Arif will talk about his initial experience with the Isopure IOL. Please, Dr. Arif, it's all yours.
Yes. Assalamu alaikum.
Salam alaikum.
I'll just share my screen.
I think this is your screen, but maybe you need to move to the first one.
Yeah. Yes. Yeah. Is it visible now?
Not yet.
Okay, I'll have to share that again. Maybe if there is any questions, you can have a discussion. I just
Actually, I have a question, Professor Ahmed. I know I will get the answer. You have just started implanting. You actually implanted the first Isopure in Egypt, and I discussed with Dr. Ala about the Isopure implantation in Saudi Arabia soon, and I know that I will get the answer from you both. The question is for Dr. Rafael, because I received such a question from different surgeons in the region. You mentioned that with the Isopure we are inducing negative spherical abrasion, and it is not highly recommended in patients that already have high corneal negative spherical abrasion. When we say high corneal negative spherical abrasion, what does it mean, high?
It's difficult to put a value, to an exact value, you know, but I would say patients with over a negative spherical aberration of over minus 0.5, I would say I would try to avoid the implantation of an Isopure. You know, the nominal power of a lens depends on what diameter of the pupil you consider, you know. So if we're speaking with the spherical aberration that is measured, for example, for the pentacam at 6 millimeters, I would say this, less than minus 0.5 millimeters,
okay.
or
okay.
microns, yes.
Microns, okay. Thank
microns,
you, thank
yes.
you. Thank you.
Is my slides visible now?
Yes.
Yes.
Okay. Assalamu alaikum. At the onset, I'd like to thank the Physiol and Mohammad Zata to invite me to come and speak with the eminent speakers. I'm actually using the Physiol lenses, the trifocal ones before. So I had some few problems with the multifocal, and the patients were not comfortable, as usual, the common complications. When this Isopure lens came into UAE about a year back, I was very happy with these lenses, and I'll just share my experience. Only a few lenses I have used it, but it is the comfort zone which is seen is very good. Many of this thing will be common because Dr. Rafael has already explained to it. I'll be just briefing you in short about the lenses. As you all know, Isopure lens is a premium monofocal lens suitable for any cataract patients, which basically wants a functional intermediate vision in all conditions. And there is no compromise on the quality of vision, because the moment you shift the lens, any premium IOL lenses, then there is always a quality of vision getting hampered, and all the complications or the features are seen. So this lenses has got a simplicity of a monofocal lens, and which gives you a good intermediate vision. Yeah. So the main Isopure optic features a non-diffractive design, simplifying the discussions for the patients who are not candidates for the diffractive technology. because the problems with multifocals mainly happens because of the refractive technology. But these patients, they want the extended range of vision and reduced needs for the spectacles. So as you all know, Isopure optic features presents a polynomial complex surface design across the full optic of the lens. It has a good quality of vision, giving you 20/20 distance vision. And the main important features of these lenses, as discussed before, is independent of the pupillary size, because they are lenses, other lenses, which depends upon the mesopic or photopic size of the pupil. But the quality of vision seen in Isopure operated lens patients are the good vision in all the cases, whether it's morning or evening or night time. That's the main peculiarity of these lenses. So what are the indications of these? It's mainly indicated for the patients who are unwilling to accept all the disturbances related to multifocal patients. So they are obviously in each surgeon's practice, you'll have patients who want the multifocal lenses, but they are not comfortable when we try to explain to them the problems which can happen, like glare or photophobia. So these patients who want a spectacle independence, but doesn't want problems related to multifocal, you can explain to them that, okay, you will not be spectacle independent for all the visions, for distance, for near distance and intermediate, but at least your main problems of distance and intermediate vision will be solved. And many patients they are willing to wear the reading glasses, they don't mind. So the patients who are willing to wear the reading glasses, and it is well indicated, it's also suitable for all the routine cataract patients. But the main thing is there should not be any ocular pathology. As discussed by Dr. Raphael, all other pathologies in the cornea or in the macula should be contraindications for these lenses. It's also high probability of minor residual refractive errors are the indications. Now, the main thing what we have to see is the target refraction should be either emetopic or maybe in 0.5 minus in the other eye if you're operating by binocular. All the corneal pathologies, patients with corneal pathologies, as discussed now, because of the induction of the negative spherical aberration should not be included, like astigmatism more than one diopter, keratoconus, post-presby Lasik or hyperopic Lasik patients. So the main target refraction should be as simple as any other monofocal implantation. And also the macular, the patients who are not able to get the maximum benefit because of the macular lesions should also be excluded from these cases. Now, what are the advantages of these lenses? It gives you a good uncompromised retina protection. The material used for these lenses is the glistening-free hydrophobic material, which gives you a good clarity, good vision, and it gives you a good high quality 20/20 distance vision unaided. There is no disturbances of halos and glare, which we normally see with the multifocal lenses, and the quality is good. Like any monofocal lenses, Isopure lenses uses all the available light energy to extend the range of focus. It does not lose any light energy through diffraction, which is seen in multifocals, and it has good contrast sensitivity compared to other monofocal lenses. So these lenses has got all the advantage of monofocal, as well as it doesn't have the disadvantages of the multifocal lenses. So it perfectly fits in between. And I have seen in my practice, when I try to explain to the patients who wants premium IOLs, many patients, they are more comfortable using the Isopure lenses than going for the multifocals. And even for patients who are candidates for monofocal, they are comfortable when they are told quality of vision even for intermediate vision. And the other important advantage is it increases the depth of focus compared to other monofocal lenses, and it has got good functional intermediate vision. And it has good vision in all pupillary sizes and in good light condition. So other important features, whenever any new lens comes into the market, we always ask the company what is the advantage, what is different in this lens compared to the other lenses. And once we are comfortable with the technology, the advantage of the lens, the next thing comes is the incision and the ease of delivery. Because the ease of the lens should be implanted comfortably. There should not be any difficulty in putting the lenses, because many times if the delivery systems is not perfect, it can lead to some complications even if the lens is good. So I'll just explain to you about this pressure release system technology, which is taken by the Physiol lenses. Yeah, this video will explain to you how you are injecting the lens. So just injector, just directly push it into the preloaded cartridge. Just press it and then wait for 3 seconds. And when you're pressing it, you will hear a click. Then remove the safety catch. And just see that the cartridge is properly locked into the injector. This is the important thing because it should be properly locked. And in case if you don't hear that clip, there is a possibility that the lens it's not properly joined. So try to do it, press it again, and try to listen to the sound. And then just like any routine lenses, just wash it with normal saline, BSS solution, and then inject viscoelastic. This PRS technology is characterized by there are two small openings which are there on the tip of the cartridge, which helps in releasing the pressure. And you can inject this in 2.2 to 2.4 millimeters. So because of these holes which are there, you are not putting too much pressure on the incision and pressure on the lens delivery. It's very smooth delivery system. So I'll just present two cases and not a whole list of cases which I have done. First is a 65-year-old male patient, diabetic. We came with decreased vision in the right eye. It's a routine case. Patient was 6/24 vision. Pressures were normal. Fundus was normal. There was no diabetic retinopathy changes, no macular edema. The routine set of pre-op investigations were done. We always do the speculomicroscopy also before and OCT examination to rule out the corneal pathology or macular lesions. And then once after examination, then the patient was explained about the different type of lenses used. He was more keen on the multifocal lenses, and then the various advantages and the problems of multifocals was explained. The main important thing is whenever you are taking these cases of multifocal lens, good chair time before the procedure is very important. You have to explain to them the advantage of each lenses and the problem which might be there. The patient underwent the phacoemulsification. He opted for the Isopure lens, and post-operatively the vision was good. The distance vision was 6.6. The intermediate was around 20/30 at about 80 centimeters, and the near vision was about 20/40. And he was very comfortable, very happy because he was able to use his the desktop because he was regular users of the computer jobs. He was very comfortable, and he was explained to him that before that he'll be using glasses for this routine reading or mobile work. The second case was a 45-year-old young patient. He had typical post-subcapsular cataract. And he was basically a driver by profession. And when after examination, the possibility of multifocal, he wanted basically a multifocal lens, but because he was a driver by profession, I explained to him that you can have this glare and photophobia. It will be difficult for you to drive every day in the night time. And then this lens, Isopure lens, was very comfortable because he wanted to have a lens where any lens which we can see the speedometers and all these things while driving. So this was the perfect lens which gives you an intermediate vision and the far vision, and that doesn't give you all the problems of multifocals. So he underwent phacoemulsification, and the post-op follow-ups, he was comfortable, the vision was good, he was able to drive, and the far vision was good. All the glare photophobia which he had because of the posterior subcapsular cataract all went away, and he was quite a happy patient, and the reading was not a problem for him. So he was comfortable using the glasses at the later stage, and he had basically the cataract in both the eyes, and he was comfortable later on. Thus, we saw the Isopure lens is the ideal monofocal lens, which has all the advantage of monofocal lens, plus it gives you good intermediate vision also. And nowadays, with the cost of the multifocal lens, this lens is a perfect lens because it's covered by the insurance, because we are facing many times the patients where the patient wants to have a multifocal lens, but the cost comes into issue. Insurance doesn't give you approval. So these lenses, which is covered by insurance, it gives you a good added advantage of intermediate vision, increased depth of focus, as well as a good monofocal near distance vision. Thank you.
Thank you very much, Dr. Arif. Excellent presentation.
My talk is very short, but I just wanted to highlight and share my experience being a new user for Isopure. Okay, which patients you have to take and what you have to explain to the patients. And yes, I'm sure the cases will increase, and I'm comfortable with the feedback given by my patients.
Yes, because this is a new lens in the market and in the region, so we are keen to know the initial experience as well as the huge experience of Dr. Rafael. So we need to know the initial experience of you as starting implanting this EDOF lens. I have a question for you. Would you implant this kind of lens? And this is for you and Dr. Rafael as well. Would you implant the Isopure lens in patients with glaucoma? And may I add diabetic patient?
Basically, diabetic patients who have got the OCT macular is normal. There is no problems in injecting. Even in glaucoma patients, I think if extensive damage to the optic nerve in that cases, but otherwise, I think there is no problem in injecting these lenses in glaucoma or patients.
Okay. What do you think, Dr. Rafael?
I would implant the lens in any patient in which I would implant a classic monofocal aspheric lens. So the answering is yes. The only thing is, if the patient has a very damaged optic nerve or very damaged macula, the patient would not get the advantage of this better intermediate vision. And this would be the only major problem I would think of, to use a technology that the patient would not benefit of because he has a more severe problem in the back part of the eye, you know. But otherwise, if the patient has a mild or moderate glaucoma or macular disease, I cannot see why not.
Yes, let me say it in other words. At least this lens won't harm the patient, won't affect the visual quality of this patient. In contrary to the multifocal lenses or the trifocal lens that splits the light rays inside the eye, and this will add more stress on the already stressed macula and the optic system, like in cases of glaucoma and diabetic retinopathy. So if you implant these kind of lenses, because it consumes 100% of the light rays inside the eye, I don't think, and I agree with the Dr. Arif and Dr. Rafael, that these lenses won't harm the patient. The patient may not get the full benefit of these lenses, but at least you didn't do any harm for the patient. Thank you very much. So I think I have one more question, maybe for Dr. Ala. I'm not sure if Dr. Ala is still here or not, because the question, he mentioned that he measured the or predict the post-operative visual quality by Hdi Analyzer, and whether the eye tracy is capable to predict the visual quality of these patients before implanting the premium IOLs or not. So would anyone of the panel try to handle, would like to handle this question?
You are muted, Dr. Ala.
Oh, he's here.
Yeah, I'm here, but
okay.
Yeah. That's good. Yeah, I like this question. Yes, thank you for raising this. Yes, the eye tracy is a wonderful piece of instrumentation. I use it, but I didn't want to put too many information in my talk. But the eye tracy is really great. The advantage of the eye tracy over the Hdi Analyzer, it can split, can differentiate between the cornea and the lens. So it gives you information about what the so-called dysfunctional lens, the degree of cataract, and also the cornea, because it has a Placido technology. The Hdi Analyzer does not differentiate between the cornea and the rest of the eye. So both devices are very helpful, very useful. If you have any of them, you can definitely rely on it in your pre-operative assessment, as well as post-operative assessment.
Okay. Any more questions?
Yes, I have one. Yes, please, Dr. Arif, and I will follow.
Yeah, I just wanted to know your feedback about this Lucidis EDOF lens, which is right now coming the market in UAE. If anybody of the panelists have used it, and how do you differentiate with the Isopure lens?
No idea. Maybe Dr. Rafael.
I haven't used it personally in any of my patients. We have used it in Clinica Baviera, and I have been speaking directly to the colleagues who work with me in Clinica Baviera, and the experience is good. The Lucidis lens works because it has a central axicon that is a conic lens in the center of the refractive lens that extends the focus. Optically, it could get a better intermediate distance vision with no correction than only modifying the spherical aberration of the lens. But this also leads to a higher risk to have a certain loss in distance visual acuity, and to a higher probability to have more unpredictable results, because it would depend on how center would be the axicon compared to the pupil of the patient. The result would be slightly different. But my colleagues have told me that they're quite happy with the lens for most of the patients. From time to time, they see an unexpected result that I could imagine is due to the fact that I have just explained to you.
I also heard that in small pupils, it's not very effective. The pupil size should be a little bit big. That's what I think.
Yes,
in small pupil,
smaller,
it is effective.
Or is too much, you know, if the pupil is too small and if it affects just the area of the axicon, then you may have some problems in the distance vision. Maybe the near vision of the patient would be better, but the distance vision, and this is the case for some patients, you know. So one of the things I like very much about this Isopure lens is predictability. You know, as Ahmed said just before, you're not doing any harm to the vision of the patient. Sometimes the earning in the intermediate or the near vision is more pronounced in some patients, depending on the power of the lens, depending on the size of the pupil, but you're not getting unexpected results. And this predictability is something that I really like very much.
Okay, thank you very much. I think it's time for the last presentation, which is my presentation. Okay, let me share the screen. So let's talk a little bit more basic, because many of the colleagues are confused when to use the premium lens and when not to use the premium lens. So let's say, in other words, when to say no for a premium lens. And I will talk in particular about the trifocal lens or the multifocal lens. For any patient that's coming from a premium lens, we have to pass with the patient through 4 steps. First step is patient counseling. The second step is clinical examination. The third one is further investigations. You have to do some more investigations. And finally, you have to take care intraoperatively about some surgical tips. But I will talk about when to stop or when to say no for premium lens. The patients that is coming into your office asking for a refractive surgery, 2 types of patients. Either this patient is coming with cataract, or as Dr. Ala mentioned, the patient is presbyope with clean lens. They are 2 different perspectives. The patient is cataract already has compromised vision, but the patient, the presbyope patient with clean lens, is difficult to handle. So first thing, with a patient with cataract, I would ask the patient, would you mind to have reading and distance glasses after the cataract surgery? And if the patient answers by no, I don't mind having distance and reading glasses after the cataract surgery, I won't discuss with the patient regards the premium or the trifocal lenses, because the patient already has no motivation. He is happy with his distance and reading glasses. So, okay, we have to stop. Don't waste your time. Just go for a standard monofocal this patient. If the patient is asked yes, is answered by yes, and he showed some enthusiasm regards the spectacle independence, so we can start now talk to the patient about the trifocal lens and the premium lens and do more investigations and try to see if the patient is a good candidate for this type of lenses or not. The other type in the spectrum, the patient that is already presbyope and comes with a clear lens and asks for refractive surgery. So I would ask this patient, how many glasses do you have? Some patients ask, okay, I have just only reading glasses. I'm okay for distance, I have only reading glasses. Or sometimes the patient is myope and have distant glasses only for distance and can read without glasses. So if the patient is answered by only, I have only one glass, so this patient is either plano presbyope, and of course, I would say no for this patient, for this type of surgery for this patient. And again, if the patient is low myope with clear lens, low myope in the range of about 2 diopters of myopia, I would say no for this patient, because this patient won't appreciate the reading or near vision with the trifocal lens compared to his crystal clear lens before the surgery. So if the patient answered, I have only one glass and I want to get rid of this glass and I have to maintain my distance and ability to read, like the low myope or the plano presbyope, I would dismiss these patients, and I don't implant trifocal lenses in these patients. If the patient is answered by, I have 2 glasses, so these patients either have ametropia for distance and of course is presbyope, so we can start talking about the potentials or the possibility for implanting a trifocal lens for this patient. So if the discussion proved that the patient is obsessive, or maybe he's a pilot or professional driver, I would say again no for this kind of personality to implant the lens. Or if the discussion proved that the patient is easygoing and has some active lifestyle, he's doing a lot of swimming, a lot of sports, and he wants to use the computer and mobile without reading glasses, and he shows enthusiasm for the spectacle independence for distance and reading, so we can go for the next step with the clinical examination and to see if this patient in particular is good candidate for a trifocal or premium lens or not. Clinical examination will include the anterior segment examination, IOP measurement, and posterior segment examination. And I would have to say, you have to stress on the type of cataract, cornea, see the tear film, and posterior segment examination. If the cataract is white cataract, I would say no. Personally, I would say no for this kind of patients, and I will just explain to you why. And if the examination...
Dr. Yes. Ahmed, if you allow me, we do not see the slides. We see only the first slide, actually.
Oh my God. Okay. So now I'm in this. Okay. Maybe I will stop. Can you see the slides right now?
Yes, yes.
Okay, let me play the slides without the show mode. Okay, so that means that I have to start from the very
if you can just quickly summarize it.
So again, four steps for the premium patients: patient counseling, clinical examination, further investigations, and finally intraoperative tricks or intraoperative events that will stop you from using the premium lens. So the patient counseling, two types of patients, as I mentioned before: the patient with cataract and the patient who is already presbyope with clear lens. If the patient has cataract, I would ask if the patient would you mind to get to have reading and distance glasses. If the patient is already happy with his distance and reading glasses, and the patient does not mind to have similar glasses after cataract surgery, so I will start talking to this patient and will go for standard monofocal lens. And if the patient shows some enthusiasm, the distance and reading glasses, so probably this patient is a good candidate for premium lens. We have to go for the next step for further examination to see if the patient is already eligible for this kind of lenses or not. For regards the other kind of spectrum, which is the plano or presbyope patients with clear lens, I would ask these patients, or they are not patients, by the way, they are candidates. They are asking for refractive surgery and they don't have cataract. So how many glasses do you have? If the patient or the candidate answered by only one glass, so this carries the possibility that this is the patient is plano-presbyope, if the candidate is plano-presbyope, or if he is low myope with clear lens, I would say no for implantation of premium lens for this kind of candidates, not patients. So, but if the patient or the candidate answered, I have 2 glasses distance and reading glasses, so this candidate has ametropia for distance and already presbyope, so maybe he's a good candidate for premium lens. We have to do some discussion and counseling with the patient to see if regards the personality, if this candidate proved to be obsessive or works as a pilot or professional driver, etc. So I would say no for this kind of personality or profession to implant this kind of lens, because they might lose the license for flying, by the way. If the candidate proved to be an easygoing with the active lifestyle and shows some enthusiasm during the discussion for the spectacle independence for distance and near, so we can go for the next step, which is the clinical examination. Clinical examination carries examination of the anterior segment, IOP measurement, posterior segment. For the clinical examination, I will stress on the cataract, the cornea, tear film, and posterior segment. So, regards the cataract, first of all, if the cataract is proved to be dense white cataract, I would say no for this kind of cataract, or for this patient to do premium lens, and I will just explain in a few seconds. Regards the cornea, you have to look for dystrophy. Sometimes the dystrophy are very subtle and difficult to see. So if you find any kind of dystrophy on the surface of the cornea, anterior basement membrane dystrophy, endothelial dystrophy, say no for this patient. If there is a tear film abnormality and the patient suffers of dry eye, even without symptoms, because most of these patients are asymptomatic and proved by the signs and the signs or an examination that this patient has dry eye, so say no and treat the dry eye. And if there is any kind of maculopathy regards the drusen or diabetic macular edema, etc., so I would say again no for this kind of patients regards the premium lens or the trifocal lens. So why white cataract? No. White cataract because there is difficulty to obtain an accurate biometry, because we need optical biometry. Sometimes optical biometry cannot penetrate through this dense cataract. Ultrasound biometry is obsolete with the premium IOLs. There is no place for the ultrasound biometry with the premium IOL practice. Of course, posterior segment cannot be assessed in this patient to see if the macula is healthy or not, although the ultrasound B scan is available, but it's a crude test to test the posterior segment of the eye. It may denote some retinal detachment or a vitreous hemorrhage or some cupping of the optic disc, but we have no idea about the status of the macula because of the density of the cataracts. And again, you may risk this patient by high incidence of Argentinian flag sign and intraoperative complications. So it's better not to promise the patient that I would implant a premium lens and you, after the surgery, will be spectacle independence for distance and near, and you are not sure about your surgery if you can pass through the this kind of cataract safely or not. So just for white cataract, I would say no. I don't discuss premium lenses with patients with white cataract. Corneal dystrophy, as I mentioned, this can compromise the light rays refraction and cause scattering and the level of the cornea of the light rays, and this will add more compromise or more can jeopardize more the optical system of these patients on top of the diffraction or the splitting of the light rays caused by the premium lens. So sometimes it's very subtle. You have to look for this, and even the visual effect is masked by the presence of cataract. So you have to look it by yourself. If you found any subtle changes on the surface of the cornea, it's better to cancel this patient as a premium candidate, as a candidate for premium IOL. Dry eye disease, again, it's very important because it's very common in this age group. In one study, it showed that these patients are asymptomatic, and although they are asymptomatic at the time of biometry, they have 77% of these patients have positive corneal staining, and the fluorescein breakup time less than 5 seconds in 63% of these patients, just at the time of biometry. And these patients, again, they are asymptomatic, and of course, the dry eye will affect the key reading measurements, which is an essential component for the all the biometry formulas we have, and this results in 1-to-1 error ratio. 1 diopter of key reading measurement error will result in 1 diopter of post-operative ametropia, and of course it will compromise again the visual quality after implantation of a premium lens. So it must be addressed aggressively before cataract surgery, before implantation of the premium lenses. So here again, for further investigations, we should go for further investigations like the biometry, corneal topography or tomography, and sometimes OCT, macula, or the optic nerve. Those are essential. The biometry and the corneal topography, tomography are essential investigations. OCT is an optional. If in doubt, there is something wrong regarding the posterior segment of the eye. So there is no way, as I mentioned before, there is no way or there is no place for the ultrasound biometry in the premium IOL practice. Regards the corneal topography and the tomography, you have to look for irregularities, and if there is any disagreement between the key readings, if you took the key readings by the corneal topography and tomography and the keratometer, if there is any disagreement, that denotes there is something wrong regarding the cornea of this patient. So it's better to say no for the premium lens for this patient. Regarding astigmatism, you have to look for the astigmatism with the corneal topography or tomography. If there is irregular astigmatism, say no from the very beginning. If there is astigmatism even more than 0.7 diopter, so you have to consider the toric versions of the trifocal lens. Look for the angle kappa and look for the coma. If there is high angle kappa or there is high coma, corneal coma, of course, we have to say no for these patients regarding the premium lens. And OCT, as I mentioned, it's an optional investigation. You can do it just in case if you are in doubt, there is something abnormal regards the posterior segment of the patient. You can do OCT on the macula or OCT on the optic nerve to measure the thickness of the nerve fiber layer. And if there is any proven maculopathy or optic neuropathy, probably to say no for the trifocal lens. Biometry, again, it must be an optical. It's better for axial lens measurement. You can verify the measurement by the optical biometer. And again, if you can see here, even sometimes the optical biometer can penetrate, but if the biometry cannot penetrate through the white cataract, of course, we have to cancel this patient as a good candidate for the premium lens. Here you can see, I would like to refer you for the new database of the optimized A constant, which is called the IOLcon.org. It's a new database just established in mid-2017. It's a substitute to the ULEAP. So if you want to go through the practice of the premium IOLs, it's better to go for a new database to optimize your A constants for better accuracy and better targeting emmetropia compared to the old standing database of the ULEAP. Now, let's see here. Okay, here. Now, regards the corneal topography, we have to look for irregular Myers, and irregular Myers can be obtained only by the placido dim image of the corneal topography, not tomography. So personally, I believe that corneal topography is better for studying the anterior surface of the cornea compared to the corneal tomography. But if you don't have topography, you can do fluorescein breakup time to see if there is irregularities on the, if there is dry eye on the tear film. But with the, as you can see here with the corneal topography, it's just subtle changes of the image of the Myers on the anterior surface of the cornea denotes there is something wrong. Maybe it's corneal irregularities or maybe it's a dry eye. So I like the corneal topography and looking in particular to the Myers of the corneal topography, because it's a very good screening tool to screen the patients regarding the tear film on the anterior surface of the cornea. Of course, we have to look for eyes or with a low amount of corneal astigmatism, as you can see, because these patients with the corneal astigmatism will get the best of the trifocal lens. Look for any disagreement. If you have multiple devices, it's better to measure the K readings with many devices as much as you can, as many as you can. And look for disagreement. If there is any disagreement regards the magnitude or the axis of the astigmatism, so it's better to postpone the surgery, because most probably this patient has something wrong, or maybe this patient has a dry eye. You have to treat the dry eye and take care of this patient and regards his dry eye or her dry eye before deciding to implant the multifocal lens. So as you can see here, this is a case of biometry by the IOL master. You can see that the corneal cylinder is 0.58 and axis, the steep axis is 72, and it's goes with agreement with Pentacam. The corneal astigmatism on the anterior surface is 0.5 and the steep axis is 73.4. So if there is agreement between both devices or three devices, so it's better now. You can go through for the multifocal or trifocal lens. If there is any disagreement regarding the axis or the magnitude of astigmatism, so it's better to reconsider again, looking at the surface of the cornea to see if there is dry eye or not. Of course, topography or tomography, it's very important to assess the quality of the astigmatism. So we have two types of astigmatism here. This is 1.9 diopter of astigmatism, and this is 1 diopter of astigmatism. But I can implant toric trifocal in this patient, but I cannot implant trifocal in this patient. Can you see the slide or not?
Yes.
Can you see the slide in this move?
Yeah.
Yes.
Yeah.
Okay. So as you can see here, this is an irregular astigmatism. Although the quantity of the astigmatism here is, can you see the slide?
Not with the irregular astigmatism, not with the regular.
Yeah, because I can have a message for that. So I will just keep it like this. Okay, so you can see here, this is 1 diopter of astigmatism and this is 1.9 diopter of astigmatism. Although this is a larger regard the quantity, but this is regular astigmatism. So I can implant the trifocal lens, toric trifocal lens in this patient, but I cannot, because this is highly irregular astigmatism. This is, by the way, one of the patients that is dissatisfied by a trifocal lens, has been implanted elsewhere and come for IOL explantation because of the bad quality of vision. The effect of astigmatism on the optical quality of trifocal lens has been studied, and adding 0.5 astigmatism would do no harm regarding the optical quality of the multifocal lenses, but 1 diopter or more will jeopardize the optical quality and the visual performance of these lenses less than the monofocal lens, making the performance of these lenses much less compared to the monofocal lens, regarding the distance as well as the near. We have to look, of course, for the angle kappa, and the angle kappa is the angle between the visual axis and the optical or pupillary axis, which is the perpendicular, the line perpendicular in the center of the pupil. You cannot measure it. They actually can be measured by synoptophore, the normal angle, the 3.2 to 5.1 degrees, but you cannot measure this angle in clinical practice, but we can have an estimate regards the angle kappa by seeing here the chord distance between the pupil center and the corneal vertex. So the chord length between the pupil center and the corneal vertex is the estimate or rough estimate of the angle kappa. So as you can see here, if the chord length between the pupil center and the angle kappa is more than 0.5 millimeter, it's considered that this is a large angle kappa, and most probably this patient would suffer from visual dysphotopsias after implantation of the trifocal lens. How we can get the angle kappa through the topography? It's quite easy. You can see it here. The distance between the pupil center and the corneal vertex is 0.22 millimeter. Here 0.59. So it's a large angle kappa here compared to the other eye or this eye. And if you don't have topography by the Pentacam, you can give a rough estimate of the angle kappa by looking at the pupil center. This is the pupil center in relation to the corneal vertex. So this is, you can see, this is the X and Y. X axis should be less than 0.4 and Y, of course, should be less than 0.4. If you have these numbers less than 0.4, so they can consider that this is a small angle kappa and you can go for implantation of the trifocal lens. This is in case of if you have only pentacam, you don't have the corneal topography. The effect of angle kappa on the trifocal lens is very well studied. Sometimes it's controversial, but I believe it's based on the type of the trifocal lens and the optics principles of the trifocal lenses. But if the large angle kappa, it will allow the light rays to hit through one of the rings of the diffractive rings on the surface of the trifocal lens, and this will cause nighttime dysphotopsias, and the visual quality of this patient would be very bad. Again, we should study the higher order abrasions of the cornea, and we have to stress on the coma, trefoil, and spherical abrasion, but I personally usually stress more on the coma. So if the corneal coma is less than 0.33 microns, I would go for a trifocal or multifocal lens, whether the vertical or horizontal coma. As you can see, this is another patient. You can see this patient has huge coma. Vertical coma is 1.4 microns, so I wouldn't implant multifocal or trifocal lens in this patient. And finally, regards the intraoperative aspects that might stop you from implanting the trifocal lens is the opening of the posterior capsule. If you have such an incidence like opening of the posterior capsule while doing the uneventful surgery, and just with a matter of bad luck, you have an opening in the posterior capsule. So it's better to stop implanting this kind of lens, and you can go for a monofocal lens, but it's based according to your experience. So if you are an experienced surgeon and you can deal with such complication with no harm, you can implant the trifocal lens with no harm. As you can see in this patient has rupture of the posterior capsule, and I could manage this case probably by doing pars plana anterior vitrectomy and limbal approach anterior vitrectomy until I cleared all the vitreous prolapse inside the anterior chamber, and still I have a good remnants of the posterior capsule. And as you know, this kind of lens should be implanted only in the bag, not in the sulcus. So if you have a good remnant after opening of the posterior capsule and still you have good remnants to implant and support the lens within the bag, you can go and implant this kind of lens with the bag with no harm to the patient. But if you are not experienced enough, so it's better to implant a monofocal lens in the sulcus or even in the bag, because sometimes the centration of this lens might be jeopardized after opening of the posterior capsule. So as you can see, I could implant the lens, and the lens were very good centered. And maybe the last moment, you can see that the patient enjoyed very good quality of vision, although she had opening on the posterior capsule. So this is to summarize what I have said. The first step starts with the counseling of the patient, and you have two types of patients, the cataractous patients and the presbyopic patients with no cataract. So they are two different entities, and you have to discuss with these patients, and if they show some enthusiasm to get rid of distance and reading glasses, you can go for the trifocal lens. If the patient is plano-presbyope or low myope with no cataract, it's better to avoid these patients, not to implant a trifocal lens. Clinical examination, you have to stress on the type of cataract, white cataract, see the cornea and exclude corneal dystrophy. Dry eye disease should be managed before go for the multifocal lens. And of course, if you have any macular pathology, or you can, it's better to avoid these patients and say no for premium lenses for these patients. You can do further investigations like optical biometry is a must, corneal topography is a must, OCT is an optional in case of you are in doubt with regards to the posterior segment examination. And if you have an bad incidence like opening of the posterior capsule, of course, you should say no for trifocal lens, but you can still implant this lens according to your experience if you could manage such complication, and still you are able to implant the lens inside the capsular bag. So let me wrap what have been mentioned in the whole webinar. We have now conflict between the spectacle independence and quality of vision, two opposite extremes. and the patient shows enthusiasm for spectacle independence, you should jeopardize some of the quality of vision. The patient should understand this. So Physiol, now with the Physiol, we have the fine vision and fine vision toric. That's the other end of the spectacle independence. These lenses provide the highest degree of spectacle independence. And we have the EDOF lens, the fine vision Triumph, which is, again, can provide some degree of spectacle independence, but less for near. We have, on the other end, the pod eye, which is standard monofocal lens, and this is for the patients that they are not interested in spectacle independence. And we have the Ancoris, the toric lens, if the patient is happy with his reading glasses or with her reading glasses and want to get quality of vision, very good quality of vision for distance, but without glasses. So we can correct the astigmatism with this type of lens, with this monofocal toric lens, and still the patient has to use the reading glasses for reading. So we have now the fine vision. Again, this is for distance and near spectacle independence more than the intermediate. This lens provides the highest degree of spectacle independence for near more than the intermediate. Of course, we should utilize this lens for corneal astigmatism between 0.5. If larger than this, we can use the fine vision trifocal, as Dr. Ala mentioned. And of course, the patient should be a good candidate for trifocal lens regarding the biometry, the cornea, the posterior segment, etc. Fine vision Triumph, it provides again the highest degree of spectacle independence, but it's focused more for spectacle independence for intermediate more than the near. We can implant this lens. This lens is more or less forgiving compared to the fine vision and fine vision toric. So we can implant this lens with corneal astigmatism, my personal experience, in about 0.8 diopters or less. Slightly irregular corneas, if you have slightly steepening in the cornea, in the inferior bow tie, or slightly asymmetric bow tie, we can go with this type of lens. It's more or less forgiving. I have implanted these lenses in a couple of patients with post-hyperopic lasing, and they are doing very good, and post-myopic laser, and they are doing very good as well. But there are some selection criteria. At least the patient shouldn't have myopic lasing more than -6 diopters, or hyperopic laser more than 3 diopters. This is my personal criteria, but of course it's open for discussion with the panelists. And again, here the Ancoris, we can implant this lens just for the distance, spectacle independence, and the patient should understand that he or she has to use reading glasses for near work. And here, what the Isopure add is can fill the gap between the quality and the spectacle independence. So we have something in between here. This Isopure lens can fill the gap between the two extremes here, between the quality and the functionality. Let's say this lens provide functional vision for distance, very good quality of vision for distance, and functional vision for intermediate, but still the patient might use the reading glasses for near. The patient should understand this. We can use this lens because it's not dioptric lens, so we can use it for corneal astigmatism of about 1 diopter, 1.1, less than 1 diopters. I believe 1 diopter is my cutoff value. Slightly irregular corneas, of course, I can do this lens, implant this lens in slightly irregular corneas, and even in cases of post-myopic laser vision correction, as Dr. Balbao mentioned. What about the glaucoma, diabetic maculopathy? Maybe we can implant this lens because we can consider it as a monofocal lens. It won't add harm to the patient and won't stress the optical system of the patients compared to the diffractive or light ray splitting multifocal lenses. So this is my final slide here. Let's say that we have a patient now asking for spectacle independence. So if the patient is happy for and is not asking for spectacle independence, okay, we can implant the pod eye lens. If the patient is asking and was interested in spectacle independence, so we ask the patient, what lens, what spectacles, what glasses do you want to get rid of? Some patients surprisingly said that, okay, I want to drive without glasses, but I don't mind to have reading glasses. So we have to address the astigmatism of these patients by the anchorage lens. So other patients would say, no, I'm used to put on the glasses on my face, but I want to read as I used to without glasses, because these patients sometimes are myope and they have developed cataract. So they want the same visual outcomes before cataract. So these patients, we may use the anchorage to correct the astigmatism and target low myopia, because these patients ask for spectacle independence for near. So we have to ask the patient if he wants or she wants spectacle independence for distance or near, or both, distance and near. If the patient asks for both, okay. If the patient is good candidate for trifocal, yes. Not sure, no. If the patient is not candidate for premium lens, the trifocal lens, so if there is not good candidate, we can implant the pod eye or the anchorage lens. Maybe we can implant the Isopure lens. If not sure, we can go for the Isopure lens. Not sure about the regards the cornea, slightly irregular cornea, maybe some corneal astigmatism about 1 diopter, asymmetric bow tie, retinopathy, maybe. So we can go still with the Isopure lens. If the patient by examination and investigation proved to be a good candidate for multifocal or trifocal lens, we have to ask the patient if he or she had laser vision correction on the level of the cornea before or not. If no, we can ask about the activity of the patient, whether she or he is interested for spectacle independence for medium or near. If she or he is interested in spectacle independence for medium distance, so we can implant the fine vision triumph EDOF lens. If the patient is interested in spectacle independence for near, we can implant the fine vision or fine vision toric lens. So if the patient had a history of previous laser vision correction, yes. So some conditions apply here regards the patient, the laser vision correction, the profile of the cornea. So this is a matter of discussion. Again, some conditions apply. If the hyperopic, we can implant the fine vision triumph. If myopic, we can implant the Isopure or the fine vision triumph. Again, we cannot implant the Isopure lens after hyperopic laser vision correction. So this is my personal decision tree regards the trifocal lens implantation. So I hope this would be beneficial to the audience, and thank you very much for your attendance. Dr. Zatar?
Thank you, Dr. Ahmad. Really, really wonderful classification.
I'm sharing the screen. Sorry for this. Okay.
Doctor, I have a question on the question panel. So for toric IOL or for IOL in general, which K readings will be taken to calculate the IOL power in premium IOL? K readings from topography or biometer?
I personally believe on my biometry. But again, there should be some degree of consistency between both measurements. At least there is no regards the magnitude of the K reading should be, the disagreement should be not larger than 0.5 diopters, and the axis should be less than 5-8 degrees. If there is disagreement, so I have to reconsider measuring again, because there is something wrong regards the cornea of this patient, or maybe some dry eye.
Or calibration maybe of the tools.
Of course, yeah.
Yes. And do we calculate the posterior and anterior K readings?
Yes, that's why I believe in my optical biometer, because I have the IOL Master 700, which with the license to measure the posterior corneal astigmatism as well.
Okay. For you, Dr. Ahmed, and I would like to take also the feedback from Dr. Ala and Dr. Rafael and Dr. Arif as well. But let me ask you first, do you have experience of premium IOL in children?
I have implanted some premium IOLs in children, but I have to discuss with the parents of the children, of the child, that this is not intended for complete spectacle independence, just because this is a growing eye and there is a and ametropia is anticipated, and the patient or the child would or will put on glasses for distance, but at least the child can read with the reading addition incorporated in the premium lens or the trifocal lens. So instead of using the bifocal glasses or multifocal glasses, or glasses for distance and glasses for near, so the child can use one glass for distance and can read with the near addition incorporated in the lens. I did about 10 cases like this, but of course, the least or the youngest child I've implanted such a lens was 9 years old. There are some issues regarding the decentration, of course, and the surgery should be very meticulous. You should do posterior rhexis, sometimes do posterior optic capture to ensure centration of the lens. There are some surgical tricks, but I would implant this lens in some selected cases.
What do you think, Dr. Ala? Do you have experience in children with trifocal?
No, I didn't do any trifocals in children. In young patients, yes, but children, no. At the youngest age I've done cross-linking, I've done trifocal was like 13 years old, but not children.
Okay.
I would do a monofocal lens for children. They have a lot of issues, a lot of other issues than near vision.
So maybe, do you think maybe we can consider Isopure technology for such a patient? I don't know, Dr. Rafael, what do you think?
I don't have any experience on cataract surgery in pediatric population, but I don't think I would consider a multifocal lens. I think the Isopure would be quite convenient, like any other monofocal lens, yes. But I have absolutely no experience in a pediatric population cataract.
Okay, Dr. Arif, you think the same as well? You are on mute, Dr. Arif.
Isopure lens should not be a contraindication, can be easily used, but no experience with the multifocal or trifocals in children.
Okay. I have another question which is related also to Isopure. We already answered this question, why not to use it in hyperopic Lasik? Simply because the hyperopic, post-hyperopic Lasik patient already has a high level of negative spherical aberration. So with the Isopure, we are increasing this negative spherical aberration and eventually the patient will not be satisfied. So we already answered this question. I think we are good. Anybody has any other question? We will try to conclude and wrap up. So thank you, everyone. Thank you, Professor Asaf, for moderating this session and for the great presentation. Dr. Ala, always a pleasure to host you and to have your really very rich experience with the trifocal. And we look forward for the publication that is going to come in the coming 1 or 2 months. We are really very looking forward for that. Dr. Rafael, always a pleasure also to have you. We benefit from your experience, long experience since you implanted the first Isopure, and we look forward to see you hopefully soon. Dr. Arif, thanks for sharing initial experience with the Isopure lens in Emirates, and looking forward to expand the use of the Isopure with you as well in this country. Thank you, everyone. And thanks to all Physiol and marketing team for the collaboration of organizing this webinar.
Thank you very much. Thank you very much. And you are invited. You are invited for iftar, by the way. So.
Enjoy yourself.
Bon appetit. Bon appetit. Thank you, everyone.
Thank you very much.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.